Assalamu alaikum, everyone. Sabka bahut shukriya. So we are coming back, meeting back after a hiatus of few months. So we will resume our project Echo sessions. We are now adding some other topics in addition to pure GN and transplantation. So our very best Dr. Agha will start with management of DKD in 2022. Over to you, Irfan.
Thank you, Umar. I don't know about the very best, but I'll drone on for an hour. Thank you, everybody. It's great to be back, and I think we're in for another good season of talks where we will all learn from each other. So I was given the charge of talking about management of diabetic kidney disease, and we were just chatting that we should have had maybe 4 sessions on this because this is such a huge topic. So what I have done is, against my best inclinations, I have not talked too much about the basic science of diabetic kidney disease and the pathogenic pathways. I have stayed mostly towards the important clinical trials that we must all be aware of, and then some ideas on how to approach this very heterogeneous disorder. So we lump diabetic kidney disease all as one disorder, and it is fairly monomorphic when we look at diabetic kidney disease complicating type 1 diabetes. But the disorder that we call type 2 diabetes associated nephropathy is a very heterogeneous disorder and has many different phenotypes and has many different clinical courses. So as clinicians, we need to learn to identify which patients are at risk and also to identify what their real risks are. So before I start my talk, I do have a disclosure for today's talk. I have been a consultant for AstraZeneca and I also speak for them. So Farxiga is a drug that dapagliflozin is a drug that will come up today. It's an SGLT2 inhibitor. So you should all be aware that I have had this affiliation with AstraZeneca. I do have it now. So before we initiate the talk, I wanted to show this graphic. This is a very, very interesting picture. So on the left side, on the y-axis, you can see 5-year survival. So the higher you go, the better. And you can go towards the right end where you have prostate cancer and the cancer that we're also scared of, melanoma, and then breast cancer and uterus cancer. And these are the 5-year survivals after diagnoses of these disorders. Look where dialysis is. We're only better than lung cancer and pancreas cancer. 5-year survivals, and these are cumulative, all comers. So this does include the 75-year-old diabetic with heart disease. But when you normalize all these numbers, the 5-year survival is actually in the 45 to 50% range. That is, half of whoever is starting dialysis today will be dead in 5 years. And that is worse than all these cancers. Sometimes this is lost on us. You know, when you have somebody who develops breast cancer, all the plugs are pulled out. Those patients go to 10 different specialists and they have PET scans and they have CT scans and they have this and they have that. And yet there's a huge number of patients who actually do much worse than them. And we don't even bat an eyelid. You know, there are a number on our shifts. And then eventually one day we stop seeing them because they had a heart attack. And the most important thing is we know about this. We know why this is happening. And I was talking about survival once end-stage kidney disease is diagnosed. Let's look at what happens to our patients when they have lesser degrees of kidney disease. So this is the NKF heat map for chronic kidney disease, where they've tried to dumb down what the risk of chronic kidney disease is for maybe 5th graders. And essentially what you see is, you know, in the top left corner, GFR is preserved and less amounts of albuminuria. bottom right corner, you're losing GFR and the amount of protein has gone up, and the risk keeps going up, even in these stages where we think that the kidney disease is not severe. There is a reason that the point prevalence of CKD3 in the general population is 6 to 7%. That is close to 30 to 40 million people in the United States, right? 10% roughly of the population. What is the number of patients with CKD4? That's less than 1 million. What is the number of patients on dialysis? That's less than 1 million too. Now, it is possible that some of the CKD is not progressing, but we know that 60 to 70% of CKD in our country is because of diabetes and hypertension. And therefore, there is progression, but there is also a lot of attrition along the way. And the attrition is because of all this heart disease fallout. We lose people to heart attacks and strokes and complications of peripheral arterial disease. So we are looking, when we are looking at this CKD3 here, we are looking at tombstoning already. The disease is a vascular disease. When you start seeing blood vessel disease in the way of microalbuminuria, you're already looking at the damage that is happening to the vascular beds of that patient. And that patient is at risk for dialysis, yes, if they survive to CKD5, because we're probably going to lose them on the way, or there's a high risk we'll lose them on the way with vascular events. And this is what kidney disease does to our patients, right? So this is the impact of end-stage kidney disease on longevity. So the red dots over here are the normal lifespan. So somebody in the 0 to 20 age group, this is their expected lifespan. Now you put these people on dialysis. If you put them on dialysis, you're cutting this person's lifespan in half right there. You transplant them, they do a little bit better, but this difference is maintained right up to the ripe years of life. So dialysis is not a good actor. It is also a very expensive actor. So, I mean, I can look at this, the panel of attendees on the right side. I know Avas and Umar talk about value-based care all day long. This is where all the scrutiny is now in the United States, because healthcare has gotten so expensive. And you can see that people with increasing degrees of albumin in the urine and decreasing GFRs, their cost of care goes astronomical. So let me give you an example, and this is for the US audience. People who have no kidney disease, they're, let's suppose a 65-year-old with diabetes and no kidney disease, their per member per year spend by an insurance company is going to be somewhere in the $6,000 to $8,000 range. Give the same person chronic kidney disease with albuminuria, let's say the GFR is 30, their per member per year spend goes to about $33,000. So that is what our system is looking at, and the system is beginning to crumble because these diseases are so expensive. So obviously something needs to happen. And this is again for the US population. I don't know how the Pakistan side is, but I think they're probably a little worse off, not better in this, that mostly almost half of the people, so this blue thing over here, almost half of the people, just under half of the people, just about 30 to 40% of our patients have actually seen a nephrologist for more than 12 months before they start dialysis. So we have no preparation to even alter their course, because we start seeing them when the GFR is already 25. And at that time, all we can do is try to prepare for dialysis. And that happens because of this large blind spot that we have in management of chronic kidney disease and in diabetic kidney disease. So when diabetic kidney disease starts establishing, you start seeing hyperfiltration. And again, If I had one other lecture to do this, I would have gone through this in much greater detail, but we'll hit the high spots. And then microalbuminuria starts developing, and we are completely unaware of this. We are not following this at all. We start picking up these people somewhere around here when either the urinalysis starts picking up protein. Once the albuminuria goes over about 300 microgram per gram, the total protein at that time is 500, 600 milligrams per gram. And if we are lucky, on the dipstick, you'll register 1+ and somebody might pick that up. Otherwise, people wait another 2 years before it's 2 or 3+ before they send them to a nephrologist. Or if the eGFR is low, and that I think is a bigger way in which we pick people up, because the creatinine moves yay up, it affects the MDRD or CKD-EP calculation. The GFR drops to 55 and somebody might, on the calculation, and somebody might refer them. But we start seeing them over here. All of this is in that big blind spot because we are not paying attention to this, we are not anticipating this, and we are not preempting this. And so the quest to manage diabetic kidney disease is, as nephrologists, even as individual nephrologists, now it is manage the individual patient, but also to manage the population. And that's where this value-based care thing in the United States is going, where we have to be chaperones to cost-effective care, but maintaining quality. And it is imperative that all of us pick that baton up, whether we are in the United States, whether we are in Pakistan, and do better for our patients. So, okay. So I'm going to start somewhere in the 1980s, US PKD and some of the other trials at that time looked at control of diabetes and so on and so forth as the only way, or as the first way, to treat diabetic kidney disease. Then came out renal and IDNT. So renal, so this is a comparison of losartan with placebo. And I want you to keep looking at the way these curves appear, because we'll show you curves that are better. And so here what we have is patients with diabetic kidney disease. We place them on losartan, compare that to placebo. And what we are looking at is a risk reduction of a composite endpoint, which includes end-stage kidney disease, loss of GFR, and so on and so forth. And so what we are looking at is when you put them on losartan, your end-stage kidney disease risk goes down, and at that time 28% is what it clocked at. That's a relative risk reduction of about 28%, and this is a composite of end-stage kidney disease or death, which is a risk reduction of about 20%. This is a doubling of serum creatinine. So you're going to hear, and I'll keep mentioning it so that we remember what we're talking about, but this has been the usual composite endpoint, or factors of the composite endpoint of all of these trials over the past 20-odd years. So doubling of serum creatinine, end-stage kidney disease, and end-stage kidney disease or death. And all three of these are in the composite endpoint. So there's a significant reduction of all of these things when that patient is placed on an ARB, which is losartan in this case, versus standard of care. Now that's a very, very important trial. This is IDNT. And here what we had was irbesartan, which was compared to placebo or amlodipine, right? So again, another ARB with a non-dihydropyridine, 1,4-dihydropyridine calcium channel blocker and placebo. And we followed, again, primary endpoint, which is a combination of end-stage kidney disease, doubling of serum creatinine, and death from any cause, so all-cause mortality. And again, amlodipine is hugging placebo pretty much almost all of the places, whereas irbesartan seems to be doing a little bit better. So again, these are the trials which established ACE inhibitors and ARBs as a staple of management of patients with chronic kidney disease, especially diabetic chronic kidney disease. They found their way into the hypertension management algorithms because of this additional benefit they provided as far as reducing progression of kidney disease and also decreasing all-cause mortality. That was the only game we had to provide our patients with diabetic kidney disease. After that comes what I call the lost decade. Now, when was IDNT? I think it was 2001. So after that, precisely for about 10 years, we marked time. This is when I entered practice. I finished my fellowship in 2002. And at that time, I hated going to the chronic kidney disease management clinics. There was nothing we could offer them apart from putting them on an ACE inhibitor. So to my mind, these were completely useless visits. Anybody could have done that. They didn't really need to come to a nephrologist to do that. And after that, study after study after study came out, which didn't pan out. There was initial euphoria. We got this new molecule. This surely will do it. And then after that, it kind of petered out. And as a result, the paradigm that developed was that we would get a referral usually in the CKD3-4 stage. We would put them on an ACE inhibitor, ARB, and then for a couple of years we would do nothing. Oh, your kidneys are fine. Your kidneys are fine. And then one day we would find that the creatinine clearance has dropped below 25. They went for a cardiac event or had a cath or something or the other. And at that time would start running around trying to make arrangements for them to go see access, go see transplant, and so on and so forth. But the important thing to note is we started with a base that looked like this, and we end up with an effective population of CKD4s and 5s that look like this. We lose a lot of patients along the way. And as I mentioned, a lot of that loss is because of cardiovascular issues. So then comes some good news. So in 2008, 2009, we started hearing about a new class of anti-diabetic medicines. On the left side, you see a kidney. We all know about 180 grams of glucose is filtered in the nephrons every day, all the nephrons put together. If you give them a drug called fluorescein, and that's the PZ over there, if you give them a drug called fluorescein, suddenly what you find is that the glucose excretion falls significantly. Glucose excretion falls significantly below the 180 grams per day. And so, I'm sorry, yes, significantly towards 180 grams a day. Normally, all of the glucose would be sucked out by the kidney. You give them fluorescein, all of that sugar is actually going to show up into the urine. If you look at it another way, if you've got fluorescein on, the urine excretion would be less than 1 gram per day. If you don't have fluorescein, you're going to lose that. So what does that mean? What that means is normally, without the drug being present, your glucose concentration in the tubule drops very significantly. So you can see over this graph here that as you move away from the glomerulus in the proximal part of the tubule, suddenly you start losing all the glucose. All the glucose is reabsorbed. And this predominantly happens in the S1, S2, and somewhat in the S3 segment. And the reason this happens is that in the S1 and S2 segments, there's a transporter called SGLT2. In the S3 segment, there's a transporter called SGLT1. And what this does is it is a co-transporter. SGLT2 picks up one molecule of sodium and one molecule of glucose, and it shuttles it inside the cell. Once they're inside the cell, they exit through the basolateral membrane. The sodium makes use of the sodium-potassium ATPase, whereas the glucose goes through an enzyme called GLUT2, a shuttle called GLUT2, which puts it into the interstitial space from which they are picked up in the blood. SGLT1 uses two sodium molecules with one glucose molecule, but same story, sodium comes in, it is picked up by the sodium-potassium pump and is shuttled in. Glucose takes the GLUT2 mechanism and goes into the blood. So what you're seeing here is there is glucose that's filtered every day, but it is completely reabsorbed and you don't see anything in the urine. So this is the filtered load of the glucose every day. If you don't do anything, you're going to actually excrete very, very little urine, very, very little glucose in the urine. But if you treat them with a drug called fluorescein, then all of that sugar is actually going to show up in the urine. So what that molecule is doing, and let's kind of, before we go on to what that molecule is doing, take a look at how this is happening in a cartoon form. This is the SGLT2 transporter. It has got an outer gate and outer vestibule. Sodium comes in, chaperones in the glucose. The outer gate closes, the sugar is trapped in the vestibule, the inner gate opens, and the sodium and sugar go across into the intracellular membrane. Now, if we use this drug called fluorescein or some of its newer congeners that we are all familiar with, empagliflozin, dapagliflozin, canagliflozin, and ertugliflozin, and it's not named after Ertugrul. Essentially, this molecule would come in. It has a leading sugar sequence which blocks the vestibule. And now what happens is your sodium and your sugar can't come up. These are just cartoon representation, crystallography, atomic model, and a recreation of how the thing works. But suffice it to say, we saw that there was an outer outer vestibule, the glucose binding site, and inner outer gates. So essentially, these molecules come in and block this outer vestibule and the glucose binding site. And now the SGLT2 molecule, transporter cannot allow the glucose and sodium molecules through. So let's take a look at what that means for the normal kidney and for the deceased kidney. So normal kidney, you've got this afferent arteriole, glomerulus, efferent arteriole. There's normal glomerular capillary pressure, and 90% of the sugar is picked up by the SGLT2 molecules along the proximal convoluted tubule. And that's the end of the story. That's how things go. Sodium and chloride journey down to the distal tubule. At the macula densa, these cells, the macula densa cells, sense the sodium, and depending on whether there's a lot of sodium or not a lot of sodium, they indulge in an adenosine-dependent tubuloglomerular feedback to maintain or release the tone of the afferent arteriole. So that's what happens in the normal nephron, and obviously there's no glucose going through. What happens when you develop diabetes? And again, I'm at pain because there's like about 15 slides between this and this. So we'll just kind of assume that these things have happened. So you are getting hyperfiltration. What that means is the glomerular capillary pressure is high. Now the blood sugars are high, therefore your filtered glucose and sodium along with it is high. The glomerulus starts hypertrophying. The kidney sizes are getting bigger at this time. And then the SGLT2 molecules are working double time because all the extra sodium is being picked up by the SGLT2 mechanism. And so what you're seeing here is a decreased sodium delivery to the macula densa that cuts down the adenosine delivery to the afferent arterioles, and you start seeing afferent arteriolar vasodilation, which then leads to increasing pressures in the glomerular capillaries. Also, there's increased renin release, which then activates the renin-angiotensin aldosterone system. You start seeing efferent arteriolar vasoconstriction, and then again that increases the glomerular capillary pressure. And also, as your aldosterone is in higher drive, you start looking at the effects of aldosterone, which we will discuss in a subsequent slide. So that is the problem in the diabetic kidney. How does blocking the SGLT2 transporter help? So essentially what we are doing here is we are blocking this, we are reversing the delivery of sodium and chloride. So now there's more sodium and chloride going in towards the distal convoluted tubule. This actually then allows the tubuloglomerular feedback to realize there's enough volume. They are going to reverse the vasodilation of the afferent arteriole, reverse the vasoconstriction of the efferent arteriole, and normalize the capillary filtration pressure. So that's the idea, because we feel, based on Barry Brenner's work, that hyperfiltration in the glomerulus is what causes some of the attrition that we see in these patients, because that then damages the podocytes, and they undergo slow but inevitable glomerulosclerosis and eventually loss of kidney function. So this is the theory behind using SGLT2s. Now, there's other mechanisms, and again, we can keep talking about the mechanisms till we are blue in the face, because there's a lot of speculation in this as well, because this is a very classic case of bedside to bench. When these drugs were coming out, they were considered anti-diabetic agents. So this entire exercise started when we started looking at the significant amount of kidney protection and heart protection, plus other benefits that we were getting. So we started going back and started looking at this, that how is this happening, right? And so the diabetic kidney is characterized by tissue hypoxia. Why does that happen? Because all of these pumps, when SGLT2 is in hyperdrive, because there's a lot of sodium, a lot of glucose, that eats energy, but then actually drops a lot of glucose and sodium inside the cell, which has to be extruded, otherwise the cell will swell and die, right? So it has to be taken out of the cell, and this is what happens through the sodium potassium ATPase or the GLUT2, and all of these things require energy. So the energy requirements of the kidney are very high, so that leads to tissue hypoxia. HIF1 is an enzyme which is transcribed when the tissue is hypoxic. So there's a little bit of a dyssynchrony here, that the HIF1 expression goes up, but the gene transcription of certain other genes that go hand in hand with this under normal circumstances is broken up. So your EPO synthesis, erythropoietin synthesis, lags behind. And so essentially what you're looking at is relative EPO deficiency despite good HIF levels. So there's essentially functional HIF resistance. And so all of these things, plus other factors that are upgraded, which lead to inflammation and fibrosis, lead to very slow, and this is a slow arc process over a year, over 10 years, you start seeing fibrosis of the kidney. When you put SGLT2 inhibitors in there, they are going to block this, this uptake, which then blocks the need for overdrive of the other energy-eating processes in the tubules, and that corrects the HIF sensitivity issues. and improves erythropoiesis as well as tissue oxygenation. So many other factors like this are going up, and suffice it to say, your tissue oxygenation gets better, inflammatory pathways are curtailed, and your fibrotic pathways are slowed down just by adding SGLT2 inhibitors. And that's some of them amongst the many things that we are learning that help with preserving kidney function far beyond just the hemodynamic actions inside the glomerulus. So we now switch to some of the trials and that we must all be aware of. So I said that there was a decade of dissolution after IDNT came out. And so in 2009, this trial started, the MRAs outcome. This was started as a non-inferiority design trial from a cardiovascular standpoint. So we were using empagliflozin, which is one of the SGLT2 inhibitors, to treat diabetes at that time. The question was, is there a bad effect of using this medicine on heart problems? So the company was trying to create a non-inferiority model that, kidneys do fine, the heart, sugars do fine, and the heart cardiovascular things do fine as well. So essentially what they're doing is they're screening patients, putting in a run-in period. During this period of time, they try to get everybody on RAS inhibition as well. And so they are now going to use placebo versus EMPA 25 milligrams or EMPA 10 milligrams a day, and then follow them up. So that's the basic design of the study. So in a sense, it's a 1-to-2 randomization between drug and no drug in patients with diabetes. All of these patients are diabetic and heart disease. All of these patients have got high risk factors for heart disease or heart disease. And the idea is, how do they do from a cardiac standpoint? Primary outcome is a composite of patients with death from cardiovascular causes, death from any cause, and hospitalization for heart failure. So hardcore cardiac endpoints. Remember, most of these patients have coronary artery disease to begin with. And look at these worms. They look much better than even the renal and IDNT worms. So there is a definite protection in the primary outcome. There's significant protection from death from cardiovascular cause. So the hazard ratio here is 0.62, so about a 40% protection when on drug. And understand, this is in comparison to standard of care. So this, we want this worm here, we want these lines here. But if you look at the comparator, this is placebo. Placebo means that they've got standard of care and a sugar pill. Well, they're diabetics, so maybe a salt pill, or not even a salt pill, some other dummy pill. And then they've got empagliflozin. And again, patients with death from any cause and patients with hospitalization for heart failure, significant protection here, significant protection here, significant protection here. So that sounds fantastic. You know, there's definite cardiovascular protection here. Unexpected. This is better than what we thought it would be like. So what about the kidney issue? So this is a rehash. Same MRAs investigators published this, I think about a year later. Yeah, in 2016. MRAs outcome came out in 2015. And so, first of all, a spread of these patients as far as kidney function is concerned. These are real patient numbers. So about 1,000 had a GFR more than 90,000, 2,000 had GFR between 60 to 90, and about 1,000 or change had less than 60 mLs per minute. So generally preserved renal function. The numbers on the placebo side are half of this, is because there's a 2-to-1 functional randomization. And again, people with less than 30 milligram per gram on the ACR, 30 to 300, and more than 300. So mostly reasonably preserved kidney function, but again, significant protection. So almost 39% relative risk reduction here, almost 45% relative risk reduction here. They nest these little curves here. Just remember, because they're not impressed by the way the big curves look, because these are drawn out, numbers are big. And so essentially what they do is they change the y-axis. So whenever you see this little curve nested in between a curve, that means they've just changed the y-axis so that you're appropriately impressed with the splay between the placebo and treatment arms. So significant renal composite improvement and significant improvement in nephropathy. So now we are looking at a drug which we're using for diabetes, but has significant cardiovascular benefit, significant renal benefit. And that's really good news because we've never seen anything like this before. And you can see that curves like this, we have not seen even in IDNT and renal. So this is really good news for the renal community. I remember having a conversation with an endocrinologist in 2016, and he was going on and on about SGLT2 inhibitors, and I knew next to nothing about them at that time. And I was like, really? Are you seeing that much of a change? And I didn't believe him. So I ran back and I looked at the study results, and I was suitably floored. So this is another graph that I want all of you to become very, 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 very familiar with, comfortable with, and not do what a lot of people do to our patients. So whenever you start somebody on an SGLT2 inhibitor, you're going to drop their glomerular filtration pressure, and they will have a little bit of a drop in their GFR. This is completely hemodynamic. You take the SGLT2 inhibitor out, and the GFR will go right back up. But don't do that. Actually, if you drop the GFR, that means they're doing suitably well the things that they're supposed to be doing in the kidney, right? So essentially what happens is, now let's take a look at this. This is from the MRAs outcome trial. The maroon arm is one of the two treatment arms. I can't remember now if the maroon is the 10 or the blue is the 10, but one of them is 10 and the other one is 25. And the gray bar is placebo. So when you put them on empagliflozin, you're going to drop their GFR. So their mean GFR drops from 76, which was the entry GFR in this trial, down to 73, 72, 71, something like that. So there's about a 3 or 4 mLs per minute drop. The placebo obviously stays about the same. But then look what happens in about a year's time. All the 10,000 patients or 7,000 patients, whatever it was in this trial, when you put them all together, you can see that the GFR in the placebo group is continuing to drop. See, it's a straight line. We've all seen this line, right? If you draw your 1 by plasma creatinine curves over a period of years, this is what they start looking like. And what we want to do is to keep these curves as flat as possible. So what happens to the treatment arm is that the GFR stabilizes. So at the time the data was gated, you look at the end GFR, it's 73 or so, or 72 and change, and it is 3 or 4 mLs per minute better than your treatment arm. It's a big deal. 3 or 4 mLs per minute. What does that matter? I'll show you why that matters in a subsequent graph. But this is important. So somebody's creatinine goes from 1.2 to 1.4 when you start an SGLT2 inhibitor. Please don't stop their SGLT2 inhibitors. The same story we had with ACE inhibitors, right? Exactly the same. You put somebody on a RAS blocker, the creatinine will go up a little bit, and then it'll stabilize. It is the same phenomenon here. You're just depressurizing the glomerulus. From the other end, with ACE inhibitors and ARBs, you're looking at the efferent arteriole. With SGLT2 inhibitors, because of the tubuloglomerular feedback loop, you're looking at the afferent side. So this again is MRAs outcomes numbers. And essentially what we are looking at here is an improvement. So there's a forest plot and improvement across the board with all of the things that we need to look at. Then came a very large program called the Canvas program. This started in 2009. This used another SGLT2 inhibitor called canagliflozin. And so the initial trial, the CANVAS trial, started to look at cardiovascular outcomes, same construct as EMPA-REG. And then we tacked on another trial called CANVAS-R, which looked at renal outcomes. And again, this was a safety study. We got a new diabetes drug, canagliflozin. We think it's great, but is it going to be beneficial or harmful as far as the heart thing is concerned? And what they were going to settle for is neutral. We just want it to be neutral so that we don't get into any trouble with cardiovascular mortality. There were 10,000 diabetic patients that were entered into this trial. Just like the EMPA-REG outcome trial, the GFR at the time of entry was about 76 mLs per minute. About 70% of the patients were normal albuminuric, 20% had microalbuminuria, and 10% had macroalbuminuria. So the follow-up time for CANVAS was about 240 weeks, and CANVAS-R was about 180 weeks. So fairly good follow-up. And again, the drug dropped the glycated hemoglobin. That was fine. It's not as remarkable. So you start at about 8, you end at about 7.9 or so. And so I always joke with my endocrine friends that this is this is actually a renal medicine with the unfortunate side effect that it may cause hypoglycemia in some patients, and it doesn't cause hypoglycemia in a lot of patients anyways. It did help in dropping some weight. It dropped the systolic blood pressure. It dropped the diastolic blood pressure. So that's all very, very good. We are looking for that. Again, cardiovascular endpoints. Again, they'll have the composite here, and they've got the little graph here to make the graphs look better. So it's dropping the hazard ratio of death from cardiovascular causes, non-fatal MI or non-fatal stroke. So canagliflozin is better. Cardiovascular, now these are the individual components of the composite endpoint. Cardiovascular causes better, non-fatal stroke somewhat better, and non-fatal myocardial infarction better. So again, it is better than standard of care. It is doing well. Now, where it really outshines the placebo group, and not that the previous numbers were not good, they are very good numbers, but we have gotten used to spectacular numbers with SGLT2 inhibitors. So a 15% relative risk reduction doesn't look as nice as the usual 30 to 40% relative risk reduction that we see for HHF. So that's your hospitalization for heart failure, death from any cause, progression of albuminuria. Now that's of interest to us, that it actually protects and drops by almost 25% the relative risk of progression of albuminuria. It decreases significantly. The hazard ratio is 0.6, so a very significant drop in the composite of 40% reduction of GFR, requirement for renal replacement therapy, or death from renal causes. That's the usual renal endpoint that we are going to use in all of these patients. And when we look at the forest plot of risks, and we are nephrologists, so we are looking at progression of albuminuria and reduction in GFR, renal replacement therapy, or renal death, significant improvement in those parameters if you were on drug. So that's very good news for us. So this prompted the makers of these drugs to say, well, let's see if they do well with kidney disease. So now we are going to look at 2 or 3 trials that focus just on kidney disease. So this is now 2015 or 16 that Credence was started. And I'm going to focus on this slide just a little bit. Look at this. This is what they're mandating. So whatever we are doing, we have to do this first. So we have to manage their lipids well, drop their LDL, put them on the maximum tolerated dose of statin. Understand statins benefit progression of kidney disease and mortality if used early. If you use them in CKD3, they're better. If you use them in CKD4, they still work. If you use them in 5 or dialysis patients, not that much of a benefit. The vessels are already shot. Blood pressure control. Everybody needs to be on an ACE and ARB. That's your optimization of medicines thing. Once you've done that, you run them in and then you randomize them. If they're diabetic, um, so this is credence. So everybody was a diabetic in this trial. And if their GFR is more than 30, if your GFR was less than 30, they won't take you in credence. And this is where some of the recommendations from KDIGO comes from, and we will talk about that. And you needed to have a albuminuria of at least 300 milligram per gram, but less than 5,000 milligram per gram. And you, as mentioned above, you needed to be on maximum tolerated labeled daily dose of an ACE inhibitor or ARB, and you needed to be on that in a stable fashion, which means you needed to be on that for about 4 weeks. So now, when you've run into that stage, you're going to randomize to either placebo or canagliflozin, and then will be followed. And these are the endpoints that we're looking for. Composite endpoint. So this is a kidney trial. Composite endpoint is end-stage kidney disease, doubling of the creatinine, and death, either due to renal or cardiovascular cause, right? So mortality, end-stage kidney disease, or doubling of kidney dysfunction. So secondary endpoints are a composite of cardiovascular death and hospitalization for heart failure, cardiovascular death, all-cause death, renal composite endpoint of end-stage kidney disease, doubling of creatinine, and renal death, and then a cardiovascular composite. So again, very thoughtful endpoints. I mean, this is what you want. In a trial like this, I don't care what the hemoglobin A1C looks like. What I care is, are these guys going to avoid dialysis and live longer, right? That's the important thing. And so the answer to that question is indeed they do. So the primary composite outcome, which is end-stage kidney disease, doubling of creatinine, or death due to cardiovascular renal issues, significant risk reduction here. And you can see that the risk reduction starts really in about the first 12 months or so. And after that, the graphs are continuously going apart. So the longer you can keep them on these drugs, the better. Highly statistically significant, and the risk protection, the relative risk reduction, is in the order of about 30% or so, more so for the renal specific outcomes. So very, very good results from a kidney standpoint. This is the risk of avoiding end-stage kidney disease, 32% protection. Dialysis, kidney transplant, or renal death, significant protection from there as well. Death from a cardiovascular cause, death from any cause. So no matter what you do, you're decreasing mortality. And in this short period of time, 3 years, 4 years, to splay mortality this significantly is really good news. So we would hope that as these things go forward, and some of these trials were terminated early, because the benefit was so significant that FDA thought that denying the benefit of intervention to the placebo arm was unethical. So the impact was so powerful. This is again the forest plot, and most of the parameters are favoring intervention. And this is, again, I put this up, same story that we saw in MRAs. You see in this the initial drop, and then stabilization on the treatment arm, and a continuous decline in the placebo arm, with a distance which is going up as time goes by. Now, sometimes people ask me, is it worth it to use these drugs in patients who have fairly preserved GFRs? And my thinking on this is absolutely. So let's take a look at this. This is a rehash of the credence data. And we've broken it down based on GFR. So in the 60 to less than 90 mLs per minute group, you can still see an improvement. It is more in the 30 to 45 ml per minute group, which answers another question, and I'll come back to that. But the effect is there. So if you've got somebody who's got a GFR of 90 and they've got maybe some microalbumin, maybe not, it is not unreasonable to give them that protection. So let's take a look at this this graph here. This is the various parameters: hemoglobin A1C, systolic blood pressure, body weight, etc., based on your GFR substrate. So the dark substrate, the black substrate here, is GFR of 60 to 90, so preserved GFR, right? And even in this, there's a 28% drop in the albumin creatinine ratio. So that's not for nothing. So if you're preserving GFR and you're dropping albumin back, I think it's absolutely worth it to try it in patients early. DAPA-CKD is the big CKD trial that dapagliflozin used. The twist on this was diabetes was not a must. So essentially what they did was they used 18 years or plus, so adult patients with GFR between 25 and 75. Proteinuria pretty similar to the Credence inclusion. Instead of 300, they had a lower cut at 200. They were all on ACE and ARBs. And then about 98% of the population was on ACE and ARB when they started the trial. They were randomized to placebo or 10 milligrams of DAPA, and the endpoints were the same. You're looking at a 50% eGFR decline, ESRD, or time to renal cardiovascular death, and then secondary endpoints, renal composite, cardiovascular composite, and all-cause mortality. And again, the curves are fantastic. You can see that after about 8 months or so, you're going to start seeing this difference. So the red line over here is placebo. Understand, this is standard of care. This is the legend on which Avas and myself were weaned off on. You put them on an ACE, you put them on an ARB, control their blood pressure, control their lipids, and that's all you can do. So that's your standard of care. You add SGLT2 inhibitors on top of that, and you have a significant benefit in your renal specific outcomes, in your cardiovascular outcomes, and in all-cause mortality. This trial saw a drop of about 30% of all-cause mortality in 2.4 years. This trial was terminated at 2.4 years, again, because the benefit was so great that the FDA thought it was unethical to avoid, to deny the placebo group the benefit of the intervention. And again, forest plot of this trial, again, favoring all age groups, all races, all ethnicities, whether they had diabetes or not, didn't matter. You can see that 2/3 of the patients in DAPA-CKD, and there were 4,400 patients in this trial, 2/3 of them were diabetic, 1/3 were not diabetic. So about 1,500 people were not diabetic, and yet in these people you see a very significant improvement. GFR less than 45, there's an improvement. GFR more than 45, there's an improvement. Albuminuria, high or low, there's improvement. So literally every place you look at, there was an improvement in this trial. And again, this is the DAPA curve. You will drop the GFR and then it will stabilize over a period of time. Placebo is going to go down over a period of time. So please, 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 when you start them on the drug, don't stop it if the creatinine inches up a little bit. Now, there's another trial which we will hear about the detailed results in about a month now at ASN. The top line results have already been declared in some press releases a few months ago. Very similar trial to DAPA-CKD, but they are taking this down to 20 mLs per minute. So now in the CKD group, what you're doing is you're taking people with GFRs between 20 and 45 and taking people with GFRs between 45 and 90 if they've got albuminuria. Because what they didn't want to was to pick up people who had a GFR of, let's say, 80, had no albuminuria, no risk factor, because I understand diabetes is not a must for this trial. So in those circumstances, it would have diluted the results in favor of the drug. So we would have said, well, these guys were not going to move forward anyway, so why are you using them in this trial? And they, again, like DAPA, they were supposed to be on an ACE and ARB. You're going to randomize them to treatment or placebo. Endpoints very similar: GFR decline, end-stage kidney disease, precipitation, or renal death. And then the other endpoint was, and the other part of the composite was cardiovascular death. So mortality or decline in kidney function. And so we'll hear about EMPA-KIDNEY in November during ASN. So it is very, very clear that these drugs are game changers. And I didn't talk about all the heart failure trials. So the way this worked was that we started the diabetes trials, found improvement in heart failure and hospitalizations because of heart failure. Then they transitioned to heart failure trials. So there's DAPA-HF, where you actually don't have to be a diabetic, just DAPA in patients with heart failure. And from there, we have transitioned to CKD trials. But what it is pointing towards is that in this nefarious cardiorenal continuum, blocking SGLT2s is doing something really, really good to our patients. It is avoiding heart endpoints, it is avoiding kidney endpoints, and it is making them live longer. And the amount of benefit that we have seen is unlike anything that we have ever seen before. Not in renal, not in IDNT. None of those trials had improvements like what we have seen now. So this is truly remarkable. And after a lifetime of wandering in the wilderness, nephrology has finally found the tools to actually impact these patients in the clinic rather than treat them in the dialysis or transplant centers. So the next thing I want to talk about, switching gears a little bit away from SGLT2s, is MRAs. And we know that mineralocorticoid receptor antagonists are of two classes, steroidal and non-steroidal, and then the newer non-steroidal MRAs are all the rage. Finerenone is kind of the class leader in that. And so what the MRAs do, as you know, is the primary thing that we have all weaned on is that the MRA receptor is lodged into the basolateral membrane. This is the sodium potassium ATPase, and that blocks the exchange of sodium and potassium, which then causes the sodium buildup inside the cell, making ENaC function difficult. So when you block the MRA receptors, you're going to have sodium that goes out, potassium that actually builds up, so a little tendency towards hyperkalemia. That's the direct pharmacologic action, but it also has significant anti-inflammatory and antioxidative actions. So I'm not going to go into the details of all of these things that happen, but what they do, these things, is eventually they cause tubulointerstitial fibrosis, and the MRAs block all of these processes. So the thinking is, by putting everyone on MRAs, we are going to decrease the slow progression of pro-fibrotic and pro-inflammatory activity that we see in diabetic and other chronic kidney disease. It also works on the cardiac and vascular nexus in similar fashions. So essentially, the important thing to notice over here is that we are looking at a very nice possibility of a synergy, right? That if you use some agents that are working in the glomerulus and you complement them with agents that are working predominantly in the tubulointerstitial as well as the glomerular compartment, then you're probably going to have sequential additive benefit. Plus, we all know that the cardiovascular disease processes and indeed chronic kidney disease processes that we are dealing with are actually inflammatory processes. So our center is involved in several trials now, which are using anti-inflammatory medicines and studying the impact on cardiovascular events and renal events. So this is how that happens. And in the interest of time, I'm not going to go into the full detail of these mechanisms. But essentially, the idea is if we add an MRA to their treatment, we probably are looking at decreasing some blood pressure issues, decreasing fibrotic issues, and decreasing inflammatory issues that lead to progression of kidney disease, that lead to worsening of cardiovascular disease. So this is a trial called Fidelio, and George Bakris has been leading this effort. And I love the fact that they're naming all their trials as if they were Italian operas. But the inclusion age, again, adult, all diabetics, chronic kidney disease defined as GFR of 25 to 60 with albuminuria. Even if the albuminuria is modest, if the diabetic retinopathy diagnosis was in their medical record, they're allowed in, or GFR of 25 to 75 with declared high-grade albuminuria. So they are then, and they are on ACE inhibitors and ARBs, and everybody's then screened and run in. And then they are randomized to two different doses of finerenone, 10 milligrams or 20 milligrams versus placebo. And again, we see curves, and now the SGLT2s have spoiled us because these curves don't look as brilliant as the SGLT2 curves, but as far as the endpoints are concerned, cardiovascular endpoints, kidney endpoints, these are pretty good reductions in risk on top of placebo. A very, very small percentage of these patients, I think less than 5%, were on SGLT2 inhibitors. It would be a very important question to ask what happens when you use SGLT2 inhibitors in tandem with MRAs. And again, the forest plot for all the different categories looks favorable towards the drug. It did drop the albumin to creatinine ratio, which is good to know. Potassiums were a little high, which is expected. So there were hyperkalemia episodes, and I think they defined hyperkalemia as a potassium of more than 5 or 5.2. Can't remember now, but there were 44 cases of serious hyperkalemia in the treatment arm. So again, we'll switch gears and to the third big category of drugs that we have to treat kidney and diabetes together, and that is incretin-based therapy. We all know incretins, this hormone called GLP-1 is a derivative of a prohormone called proglucagon. The proglucagon is spread in various tissues of the body, and it depends on what prohormone convertase we are dealing with, which would cleave the right type of end molecule. So in the enteroendocrine system there's the largest endocrine system of any place in the body is in the gut. We don't even know about it, but there's a cell called the L cell, which has this prohormone convertase 1, which breaks this proglucagon to generate GLP-1 and GLP-2. And this actually is released in response to meals. So when we eat something, the GLP-1 comes out, and then it helps in dealing with some of the responses that are required. Now it can also be released by bacterial byproducts and bile acids and so on and so forth. I'm not going to go into the glucagon arm. That's not directly relevant to our talk, but when GLP comes out, it attaches to a GLP receptor. It decreases reactive oxygen species production, decreases inflammatory cytokines, and so that's kind of how some of the positive effects of GLP-1s are promulgated. Obviously, it decreases hyperglycemia by increasing beta cell insulin stimulation, insulin secretion stimulation. Now, just to make a point, DPP-4, dipeptidyl peptidase 4 inhibitors, your sitagliptins and all actually block the dipeptidyl peptidase 4, which breaks down GLP. So using these molecules increases the GLP levels as well. In the diabetic kidney, so imagine this is a diabetic kidney, you've got increased glomerular pressure, your afferent arteriole is vasodilated, your efferent arteriole is vasoconstricted, the opposite of what we want. What GLP-1s do is they decrease the activity of sodium hydrogen exchanger as well as glucagon action, which decreases tubuloglomerular feedback and causes vasodilation vasoconstriction of the afferent arteriole. And it also decreases reactive oxygen species generation, decreases the activity of the angiotensin system, and causes vasoconstriction of the efferent arteriole. So it does what needs to happen to decrease the pressure inside the glomerulus. And they do seem to work. So these are the 4 leading trials of GLP-1 inhibitors, all against placebo. And what we are looking for is the renal effects on this. So in the Excel trial, we were looking at reduction of new microalbuminuria or an endpoint of 40% GFR decline, renal replacement therapy, or death from renal disease. And compared to placebo, they decreased all of these. So that's a good thing. In LEADER, which was liraglutide, in Excel, we used exenatide. In LEADER, we used liraglutide. And again, the endpoints were albuminuria, doubling of serum creatinine, drop of GFR, yada, yada, yada. And the treatment arm did better than the placebo arm. Sustained, we used semaglutide, and it again performed better. And in REWIND, we used dalaglutide, and again, it did better. And the endpoint here was new macroalbuminuria and greater than a 30% eGFR decline. And it's because of the endpoints that you see more patients achieving them on both arms. So in the 21st century, in the year 22, maintaining vigilance and effective control of your diabetics is very important. And as kidney doctors, we have to focus on all of this. This is all our job. We have to modify their lifestyles. These are the basics. We have to address what their demographic risk is. For us in the United States, if they're African American, especially APOL1 positive, that right there is a much higher risk. If they smoke, much higher risk. Clinical parameters, hyperglycemia, we need to control sugars, control blood pressure, have them lose weight, control their lipids, like I mentioned a little while ago, aggressively. We've got all these different armamentariums now, drugs in our armamentarium now to do that. But it is important for us to start defining phenotypes of chronic kidney disease. And there's a huge need for markers to tell us what is the risk of one person progressing fast compared to the other. I think clinically we use the Tangri equation, which is lame because all it looks at is a spot look at GFR. But in today's time, a whole host of insurance companies, as well as value-based ventures, are looking at ways to define risk, which patients are going to progress, so that we can prepare for them. But take a look at this picture. I've shown you this graph over and over and over today, that when you start somebody on an SGLT2 inhibitor, their GFR drops, but then it stabilizes, right? But if you don't have them on an SGLT2 inhibitor, they are going to drop their GFR. So if you're able to effectively, at an early stage, place them on SGLT2 inhibitors, their GFR slopes cross at a year. But let's look at the benefit we're looking at. Theoretically, this is a paper out of Kidney 360. Theoretically, what you get is about a 15-year freedom from end-stage kidney disease by just doing this, because we are looking at these things gated here. But if you project them out, right? So if you say that the loss of GFR in the treatment arm is 2 mLs per year, and it is 5 mLs per year in a well-controlled diabetic on standard of care, you're going to then protect them for 10 to 15 years of onset of dialysis. This just blows your mind when you start looking at this. And the second thing I would leave you with is that it seems, and we are looking at this now, but it seems just because of the way these drugs work, that these things would be additive. So you've got somebody who is a diabetic kidney disease patient with albuminuria. This is how they are going to drop if you don't treat them. And in a few years, you're going to see them in the ER starting dialysis. You put them on an ACE inhibitor, ARB, you get roughly a 20 mLs per minute, 20% relative risk reduction. So the curve starts straightening up. You add a SGLT2 inhibitor, this gets better. You tack on an MRA, it gets better still. And so what we are doing is moving them along. So this is when they are starting renal replacement therapy. So if you've got them on no treatment versus if you've got them on appropriately aggressive treatment for their disease, multi-point therapy, you're going to get them years before they have to start renal replacement therapy. And this, again, the point I was making a little while ago, it is essential for us to understand the phenotypes of DKD. Type 2 DKD, DKD complicating type 2 diabetes is a totally different animal than DKD complicating type 1. And so there's different types of these, different courses of these, and we are very, very at a very pedestrian stage to do that. All we can do is look at albuminuria and look at GFR and then look at their course. We can monitor the albuminuria. Sometimes we do see them regressing, once we treat them, but sometimes we don't. But this is where I think a lot of work is going in. A lot of markers are coming on, your KIM1s or your interferon, TNFR1s and TNFR2s and all that. And so that is going to create a composite risk, green, yellow, red. And if they're red, we know they're going to drop fast. If they're green, we know they're going to take their time. And so that's how you can define which people to really focus on. In my practice, I am, introducing blanket systems where we are auditing all DKDs, all CKDs, and trying to give green, yellow, red report cards with whatever we can do to our nephrologists so that they can identify the people at highest risk and focus on them first. And so this is from the KDIGO guidelines, and I just wanted to point something out here. So they have actually added, to their credit, SGLT2 to metformin as first-line therapy. So that's great, but they still have this GFR less than 30, do not initiate. This is from the Credence data, but just looking at the DAPA CKD, and now when we actually get to see the EMPA kidney data in a few weeks, this is going to change. So I actually put them on SGLT2 inhibitors right up to about 20. But if you put them on an SGLT2 inhibitor, let's say GFR 25, and then a year later, a year and a half later, you're starting them on dialysis, once anyone starts dialysis, you got to take them off. So I would leave you with this final thought. You're seeing in your clinic a 55-year-old male with a BMI of 32, diabetes diagnosis of some factors of the metabolic syndrome. They've got diabetes, hypertension, hyperlipidemia, hemoglobin A1C is controlled 6.5% on metformin. Urine microalbumin creatinine ratio is 20, lisinopril 40 milligrams a day, blood pressure is well controlled, kidney function, let's say GFR is 60, on atorvastatin with an LDL of 70, and on primary cardiovascular prophylaxis with ASA. What options do you have to treat this patient? If you were treating this patient today, how would you treat them? That's the question I would leave you with. I'll welcome any questions, any thoughts, or any comments that you have. Thank you for your attention. Thank you, everybody.
Excellent, excellent. I should say outstanding. Thank you, Dr. Agha, for the most comprehensive and wonderful presentation. So allow me to add something or maybe share my thoughts. So I remember, I think what you just said in the beginning is exactly what I identified with. When I was doing my fellowship, this was, in that last decade you just mentioned, my chief said that, he was so bored of DKD and CKD that he said exactly the same thing. Anybody can put patients on lisinopril ACE inhibitor, ARB. There's not much for us to do. So he was quite probably bored that day. And then he said, I'm really waiting for something new. And then a few months later, he introduced me to this new trial of the drug called atrasentan. So atrasentan was another failed story in that lost LOST decade. That was a SONAR trial, which we did, I think, for 3-4 years. And then they had to stop the trial early, not because of the efficacy, but because of the inefficacy. So really, it took all nephrologists almost 20 years to have these paradigm shifting drugs available to us. So I am saying this because this is a discussion, I think, for the last many years. The big chunk of our CKD progression was gone. We just cannot do much. You know, somebody has proteinuria, they are on maximum tolerated dose of ARB. You cannot do much beyond blood pressure control, diabetes control. Now we have some therapeutic drugs, whether those are MRAs or SGLT2s or the GLP drugs. Not only that, they are helping with the CKD progression, so slow down. Finerenone, you mentioned, is like a 5th reduction, SGLT2 even better. They also help us to track those endpoints and see improvement in albuminuria. And you see that ADA, American Diabetes Association, you know, their expert reviews came after the KDIGO. The slide you show on from the KDIGO, I have the same slide, but I added finerenone, for example, as an additional box with the disclaimer that because the finerenone is available after the KDIGO finalize their recommendation. So right now, dapagliflozin and finerenone both are FDA approved. So the question is, what's next? We have these new drugs. They are effective. Not only they are effective. I mean, for example, SGLT2 started as a diabetes drug. Really, it's a CKD progression drug and a heart failure drug. This is how, you know, how serendipitously it is very effective. MRA, likewise, the Fidelio and Figaro trial of finerenone. Actually, I was the site PI for our site as well. So it actually makes you feel good that you did the trial and something has reached to the finish line. So question is what to do next. I think it's upon all of us as nephrologists to take over, start prescribing these drugs. So get comfortable with the new drugs. Right now in USA, the biggest hurdle is insurance, the approval, prior authorization, but eventually those hurdles will go away. Eventually these hurdles will be, the drugs will be available all across the world. So really it's up to us to learn about these drugs, start using. And what these both Bayer and AstraZeneca, what they are doing, I think they are doing more and more trials. AstraZeneca reached out for a trial which they are combining some of the drugs which are already out there. Likewise, the finerenone team, they have some plans for, I think, next 5 or 10 years, plans of different trials, different combination already planned. So there will be, these are game changers, and there will be huge influx and utility of these drugs. So really, it's up to us now that how do we manage the diabetic nephropathy in much better way that we can be. I just think, like, you know, if a patient comes to my clinic, the patient you just presented, patient in 50s and 60s, if there is still a lot of time for them to delay the onset of dialysis by 10, 15 years, and that is meaningful. So I stop here. I'm sure there are many questions and comments. Ahad, you want to go next, and then we will go with the chat questions.
Okay, so thank you so much. Firstly, thank you so much, Umar, yourself, all of the Awais, as well as Irfan Bhai, for sort of, I wouldn't say restarting, but sort of bringing the program back. But so thank you to all for arranging this for us. Number two is that, you know, my question is more to do with what do you do with SGLT2 and acute kidney injury? So day in, day out, we receive calls from the cardiology floor. So you've got these patients who are in overload. They're already on an SGLT2 inhibitor. We've seen that when you give them a high dose of a diuretic, the creatinine goes up even further. And they're already on, you know, an ACE inhibitor as well. So do you have any experience as how do you take the SGLT2 inhibitor for that amount of time and reintroduce it later? So yeah, I just wanted to sort of touch base with what are you guys doing there?
Should I tell you our hospital policy?
Yeah, absolutely. Go for it.
Yeah. So in our hospital, definitely there is some indication when patient come to hospital with very acute like a condition, like a patient ICU or patient for surgery or some acute situation. In that case, we do stop SGLT2 because it can increase your risk of ketoacidosis, because that's why we do stop it. And if patient needs a very high dose of diuretics, patient is CHF, at that time we cautiously also tend to stop SGLT2 for the time being. Irfan, any?
Yeah, no, I agree totally to what you said, but let me just kind of add a couple of thoughts to that. The first thing is, when we start somebody on an SGLT2 inhibitor and they have a jump in creatinine, that's a different scenario than what you have said. So let me kind of parse the two out. So the first thing is, you got somebody on an ACE inhibitor and let's say thiazide diuretic, and you add an SGLT2 inhibitor and the creatinine was 1 and now it's 1.8, and you're like, oh, what happened, right? So in those circumstances, you have to kind of carefully assess the volume status. Sometimes in patients who are tenuous on the volume status, I actually hold their other diuretics for a few weeks. The SGLT2 inhibitor gets into steady state in a week or so. So if they're hypovolemic to begin with, then the normotensive intrarenal dehydration stimulus to them is going to be meaningful. Their creatinine is going to go up, and you're going to get worried about it, and rightfully so. So what you do is you pull back the SGLT2, make their volume status correct, and then reintroduce it. And most of these people are able to take it. So that's one scenario. The other scenario is where somebody is in obvious volume overload because of congestive heart failure. Now, in that situation, the SGLT2 inhibitor conversation is a little, tangential. It doesn't, you can stop the SGLT2 inhibitor, but as nephrologists, one of the humble pie I've eaten is in diabetic kidney disease, where I was bored, and now it's so fantastic to take care of diabetes patients in our clinic. The other place where I've eaten humble pie is I always used to fight with cardiologists who were talking about decongesting the kidney, and I was like, what is that all about? But now I have converted, because cardiorenal physiology, and somebody with obvious volume overload, don't look at the creatinine that much. You have to diurese them. You have to allow permissive hypercreatininemia. You have to decongest the kidney, and the kidney will eventually get better. I think Awais does that more than any one of us, and I welcome your views. So if there's somebody like this who's in decompensated heart failure, they're in obvious volume overload, creatinine is going up, it is of no consequence. You can hold their SGLT2 inhibitor for a few weeks, but at the same time, don't let up on the diuresis. You have to decongest them appropriately. You have to get them to a better volume status, and the kidney will stabilize. And once they're in some steady state, you can then re-challenge the SGLT2 inhibitor as well. But I'd welcome Avais's viewpoint, because his overlap with some of these heart failure types is probably greater than most of us.
Yeah, exactly. That situation, when we do diurese a patient and patient creatinine goes up, the cardiologist would come say, okay, stop it, creatinine going up. But what we do now, other people also should look into it. We have bought our own ultrasound. We make round, we do our ultrasound, we actually look at the lung volume. And if patient is creatinine going up, but the patient showing a lung edema, which is very easily actually, we are at the beginning of learning about ultrasound of the lung. Very easy to look at into it. If we still that B line and patient has edema, we tell them that, okay, let it go, the creatinine go up, but patient still needs diuretics. And so exactly, creatinine will rise because of the congestion also. And at the same time, the BUN creatinine ratio also goes high in both cases, in pre-renal and when patient has congestion. Because at the renal level, the mechanism is almost same when the increased absorption of the BUN. So that's very, very important. Whatever tools you have to reevaluate the patient's volume status. If patient is volume overloaded, then do not cut down your diuretics, or maybe cautiously monitor patient's renal failure, renal function, and volume status.
Yeah, the other thing is that these drugs exert their good effect in a long term. So they slow the progression of the diseases. They're not active. Some of these drugs are not like active management of heart failure or active management of diabetic nephropathy. These are so if the slippery slope of CKD progression, they slow down or the hospitalization for heart failure. But once, everything is out of the control, patients are in acute decompensated congestive heart failure or acute and chronic kidney disease or acute rise in creatinine. I think holding these drugs for a few days, I don't think we will lose that much. It's really the important thing to remember is that once the patients are back in more steady state or stabilized state, we must resume these drugs like we do with our ACE inhibitors and some of the other drugs. So that those principles should be followed. But great question. There are some questions in chat as well. If Dr. Agha, you want to take a stab on that.
So let me kind of take a look. So there's, please comment on, so that's Dr. Aurangzeb, a comment on semaglutide with minimum GFR. Aurangzeb, can you elaborate your question? Are you asking whether it's okay to use it with low GFR patients?
Ji, Assalamu alaikum. First of all, sir, thank you so much. Once again, it was a wonderful talk. Learned a lot. Yes. My question is this: what's the minimum GFR? And if there is a minimum GFR, is it due to the lack of data or the evidence?
I think a little bit of both. I mean, I don't really use a minimum GFR for GLP-1s. I use it in patients with very low GFRs as well. Like I said, even for SGLT2 inhibitors, I initiated their GFR is above 20. There's plenty of data now that we can do it. And there's a benefit. And actually, if you parse the data, the rapidity of benefit is faster in the lower GFR groups. So yeah, you can use GLP-1 in very low GFRs. You can use an SGLT2 in GFRs as long as they're above 20. I saw another question about why do we take them off? That was again your question, Dr. Aurangzeb. Why do we take them off in ESRD? So the thing that makes them work, we think, is they get filtered and then they block the SGLT2 inhibitor receptors. And so if the primary action is gone because they're now on dialysis and residual renal function is significantly less, then I think that's why the companies have said it's probably better not to use them. And I have never used them in anyone who has started dialysis. So that, I think, data does not exist to my knowledge.
That's true. There wasn't any data as far as I last checked. So
yeah, they haven't really, because it seems to me based on animal models that it's not going to be very effective when the GFR is really, really low. So that's that. And then there was a question about type 1 diabetes. So there is compelling arguments to use it as an adjunct in some type 1 diabetic patients, but at this time, none of these agents are approved for type 1. So when you're practicing, especially if you're practicing in the United States, stay within the reservation because the risk of DKA goes up. It is exceedingly rare though. I mean, I'm just going to pull this number out and I may be wrong on this, but DEPA CKD, the whole cohort, I think there was 1 or 2 out of 4,000 patients looked at for 2.5 years, 1 or 2 episodes of euglycemic DKA. So it's vanishingly rare. But when you see one, you know that it can be serious and it's very easy to miss.
Fine. Surprisingly, we are seeing still, maybe that's not correctly diagnosed, but we're still seeing some patient with that. Yeah. So that's why I have to be cautious. So other important question, if I maybe jumped into, very important question is that use of SGLT2 in other GNs, glomerulonephritis. So I would like to have your opinion, but because you're the guru in glomerulonephritis things, but I think there There is a data that IgA nephropathy, there were some patients who were included, they found to be including the trials, and they did have some benefits on that. Like other conditions like adaptive FSGS, okay, not the immune related. Is there any role in those patients, you think?
So again, you framed it out absolutely perfectly. So those are the two main groups where, so if you really think about what's happening in those patients, is in IgA nephropathy, especially the low burn IgA nephropathy with a little bit of mesangial activity, what you actually have is low levels of inflammation in the kidney and eventually glomerular sclerosis. And these are the people who eventually develop segmental lesions. So on their MES score, they go from S0 to S1 over a period of time. And so if you can add an agent, so how do we treat these patients today is RAS blockers, right? And the reason we use RAS blockers in these patients is because we are trying to decrease glomerular pressure so that glomerular sclerosis is slowed down. So essentially, that's tailor-made for an SGLT2 inhibitor, just as is non-diabetic chronic kidney disease, that it is going to decrease glomerular hyperfiltration. And so in the DAPA-CKD cohort, there were about 400 IgA nephropathy patients, and there was a definite signal towards improvement. There have been subsequent publications on that. Actually, just as a point to note, 400 is more than STOP IgAN and testing one put together. So the IgA trials are very small. So this, by default is the largest single IgA trial. The trial is not powered for it though. So it's a signal, it's an observation, but it seems to make sense. Similarly, FSGS. Now we have to be careful which FSGS we're talking about. So you framed it perfectly that we're talking about the adaptive FSGS, not the immune factor related FSGS. And the problem in adaptive FSGS is no matter what the inciting factor, the progression of disease is because of hyperfiltration and progressive glomerular sclerosis. So if you can decrease intraglomerular pressure, you're going to help that patient. RAS blockers is what we used to do for these patients. Adding an SGLT2 inhibitor is probably going to have an additive benefit. So your observation is spot on.
Thank you. And there's a question from my lovely friend Dr. Ali Ashraf, regarding head-to-head trial comparison between SGLT2 MRAs or in sequence or in combination versus placebo. Do we have that data out? Dr. Agha, do you want to take this question first?
Sure. So in Fidelio, there were less than 5% of patients who had SGLT2 inhibitors on. So, I mean, it's a very small number to really make a call on whether the effective additive or not. But the makers of finerenone, I think they're Bayer, I think makes the drug, have started another trial called FIND-CKD, which is looking at non-diabetic proteinuria chronic kidney disease. And they're encouraging their patients to, they're mandating ACE inhibitors, but they're encouraging their patients to be on SGLT2 inhibitors. So that would actually generate a very nice subset of patients where we'd be able to see ACE, SGLT2, and finerenone versus ACE and finerenone for non-diabetic proteinuria chronic kidney disease. So that'll be an interesting observation.
So thank you. And in real world, who will be in the ideal position to run this trial? I think this might be better with an investigator initiative, like somebody who, I mean, I don't think Bayer or AstraZeneca would do this trial together, but if there is the funding for investigator initiated trial, but there is a lot of appetite to exactly test the same, compare the two drugs. You can use the two drugs, based on some of the recommendations, and nobody's asking you not to use them in combination.
100%.
So it's actually can be used in sequence or tandem. The ADA recommends in diabetics with the SGLT2 inhibitor, as that comes first and then the finerenone if you cannot use SGLT2. If they have more proteinuria, I think the finerenone was taking some maybe a higher score as the first line agent. But right now we will see, I can imagine some practice pattern changes in near future, that who goes first and who comes later. But I see both of these drugs and some other combination, like a cocktail of the drugs, used kind of for most patients with CKD, with or without diabetes, with or without heart failure.
And one other thing to keep in mind is each one of them costs $500 a month. So this is very expensive treatment as well, and people are beginning to do cost benefit analyses of this as well, that what is the bang for the buck that we're going to get. But from a science standpoint, yeah, I would like to put everybody in combination therapy, because these are complicated patients. And the thing is, we look at them in snapshots, and we look at them in snapshots when they're doing okay, but then they don't do okay for long. And then one day they stop coming to see us, and it turns out that they died of an MI.
Excuse me. I have a question regarding the side effects of the SGLT2. The UTI is the most common one mostly in the females. So what should be the strategy at that time to stop the drug, and again give when we have to treat them for the UTI and then start the drug again, or what is the scenario at that time?
Yeah, so anyone, Aves, you want to take that? I don't want to.
Yeah, what we do, if we have one time, we treat it with the diflucan. I mean, it's very simple to treat them. Not we, but endocrinology, but that's what they do. 1 or 2 doses and easy treat. But if it's recurrent, then patient cannot have it. Then we stop it.
And the good thing is there's other alternatives, right? So if you can't use an SGLT2 due to whatever reason, if they're developing euglycemic decay, you would probably pull it off. If they're developing recurrent significant urinary tract infections, you'll probably pull it off. Then you can use something else. But I treat my transplant patients with this. Anybody who gets a transplant, especially if they have a history of diabetes. So I get their stent out at about 4 weeks. And by that time, I've started them on an ACE inhibitor. I titrate that up. When they hit the 2-month mark and the kidney function is stable, ACE inhibitor dose is stable, I put them on an SGLT2 inhibitor. And I think I can count only one patient, maybe one, I think, who I had to actually take the agent off because she developed 3 urinary tract infections and I couldn't keep her on it. But mostly, and kidney transplant patients get UTIs very frequently. We're able to control it. Genital fungal infections are a concern. And so you have to be very careful, and just telling them to be clean is sometimes patronizing and not well received. But you just have to be consistent in your or persistent in your counseling about that. But again, I do this for my transplant patients who are on high dose immunosuppression, and they tend to do okay. We haven't had too much of genital, fungal infection. Like I said, one patient who developed 3 urinary tract infections, so I had to take her off. Other than that, people tolerate it okay. But you will have to, I focus on the 90% that I'm able to get the drug in. There would be people who would not tolerate it, who would not like it, who would have a reaction to it, real or imagined. So, that's like with any other drug that we use, you kind of can't put everybody on it. But our goal should be that this should be considered standard of care, and our goal should be to get as many people as we can on these agents, just because the benefit is so fantastic.
Yeah.
Dr. Agha, yes, please.
No,
please.
no, go ahead. I think because I have another question which I want to take. Dr. Kessel, please finish
Yeah,
your.
I have a last question regarding which is the better one in your advice, that DAPA or EMPA? Because the debate is going on that cardiovascular mortality and morbidity is better with DAPA than EMPA. And regarding the kidney, what is the scenario in that one?
I think, to be very fair, all three of them, CANA, DAPA, EMPA, they're about the same. I don't have a lot of experience with R2 glofulizine, but all the other three I've used, and my usual default is get them whatever the hell their insurance would pay for. Each insurance has a favorite, and so we try to say, okay, which one's on your formulary, and whatever is on your formulary, we'll prescribe that. I didn't go because of time, I didn't go into the side effects. So in the Canvas studies, there was a signal, there was a signal towards amputations. And in the Credence trial and subsequent studies, that signal has not panned out. But canagliflozin had that black box for amputations initially, but that has not panned out at all. And I don't really think, based on their structures and PK profiles and pharmacodynamic profiles, that we should really think that any of these drugs is significantly different from the other ones. So I use them interchangeably, and I prescribe whatever their insurance would pay for. I don't know what other people's experience.
If you go in more details, all the trials, I mean, there is slight difference. I mean, on only maybe theoretical importance, because I think that DAPA had less indication for cardiovascular disease only, not the CHF. But practically, I mean, there's no difference between all these. I mean, particularly two, like DAPA and EPA, I don't think that there's any difference. Whatever is available should be used.
And right now, it's very difficult to get one or the other for Medicare patients. It's like, for us, it's based on whatever the formulary they have. So
yeah, exactly.
I have the same approach, whichever you can get. It's really the mindset that you're going with these drugs to slow down the CKD progression. So maybe I think if we can take this question by Dr. Ali Ashraf, very good question. And let me rephrase this. So the question is regarding albuminuria, quantification of albumin in the urine as a screening tool for advancing diabetic nephropathy and as a therapeutic marker. So the first question is that if there is not much albuminuria, patients have established diabetic kidney disease. Maybe there was albuminuria and now it's not there because of the ACE inhibitor and or the duration of the diabetes is not enough to start the albuminuria. So if you don't see albumin in the urine, should you use either SGLT2 or MRA? So the follow-up question is that now you have somebody with proteinuria, you started them on this drug, you achieved your therapeutic target of the albumin less than 300. Do you add the other drug? Or maybe if I can add something, that what if you think that you stop the drug you're on? So Irfan, so if somebody doesn't have proteinuria, should you consider in diabetic nephropathy? Second is, if somebody improvement of proteinuria, should you just take it as a stop the original drug, or should you not add something?
Well, the way I look at it is, first and foremost, we have to start looking at this as CKD. I mean, diabetes causes CKD, but there's ample data now that non-diabetic CKD benefits from it just as well. So I think the mechanism is slowing down of the glomerular hyperfiltration and also countering the oxidative stress and inflammatory pathways that are unleashed in the sick kidney, diabetic or non-diabetic. So that is one. Now, the second thing is, we're not actually titrating anything at all. So essentially what we're doing is we put them on an ACE inhibitor and then add an SGLT2 inhibitor, right? That's what the studies are designed as. So we can answer questions based on the data that we have. So at that point, you're not titrating anything to an albumin level. I mean, urine albumin excretion is a marker that tells us that there's some glomerular damage, But with or without that, we are going to treat them on these patients, on these agents. So it's not like you're going to do Farxiga on and then stop it if there's no albuminuria. You'll put them on and you'll keep them on it. That's the second thing. The third thing is, do we have data for this? Yes, we do have data for it. So there are patients in DEPA-CKD who had albuminuria of about 200 milligram per gram. There are patients in Credence who had albuminuria of 300 milligram per gram. But you have to look at the patients who were in the non-kidney trials, right? So when you look at the Canvas project, when you look at the EMPA kidney outcomes, sorry, not EMPA kidney, EMPA-REG outcomes, you have patients who are normal albuminuric who are going on these patients. And then we are looking at those patients and seeing what their kidney outcomes are like. And there's a protective effect over there as well. So the question to answer about, are these drugs helpful from a kidney standpoint with higher GFRs and lower levels of albuminuria or no albuminuria, is answered not by the kidney trials, but the subgroup analysis of the heart trials and the diabetes trials, right? So that's where I look for them, because in DEPA-CKD and in Credence, they've all got kidney disease. However, when we look at EMPA kidney in a few weeks, there is a discrete subset of those patients whose GFR is low, who may not have albuminuria. So we'll get that answer even in a kidney disease setting of whether it is beneficial or not. And the third thing is albuminuria going to help us stratify patients who would benefit from an addition of a third agent? So you got ACE inhibitors or ARBs, then you add an SGLT2 inhibitor, and then the decision point of adding an MRA, that to my mind is an unanswered question and should not and cannot hinge on albuminuria alone. We are not trying to shoot albumin there. What we are trying to do is theoretically turning off the inflammatory pathways in the kidney, decreasing tissue fibrosis. Has that been shown in a trial yet? That trial hasn't been done yet. So again, FIND CKD might help us partially answer that question.
Thank you. Excellent. I think this is probably the best answer as of today. I can imagine our answers will get fine-tuned and improved in future once we have more data. All right. Any other questions? Anybody else wants to ask anything, say anything?
Okay, I have another question. Actually, what happens then when we talk about diabetic nephropathy, because the SGLT2 is such a exciting topic and such important that majority of the discussion is restricted to that. And we sometimes don't talk about the other problem. So in diabetic nephropathy, anemia is another problem, okay? And we have seen that it's mostly iron deficiency anemia. And if you go oral iron supplement, it doesn't get absorbed much. And you have to give the IV. Is that also, Irfan and other colleagues, your experience also that those patients has, if you give oral iron supplement, it doesn't improve their iron stores?
So, yeah, I mean, it has been very, very well described that in any inflammatory state, when your IL-6 levels are high, IL-6 stimulates hepcidin release from the liver. Hepcidin actually blocks ferriporphyrin 9, which is the pump which picks up iron from the gut. So that is why anyone who's got advanced stages of chronic kidney disease find it hard to absorb the iron, or the bioavailability of oral iron is lower in these patients. So, you know, my experience in this has been, and I don't take care of a lot of CKD patients, so I kind of and squirming a little bit in my chair when I say my experience, because my experience is maybe 10 years old on that. I've been pretty much taking care of transplant patients since that time. But my experience has been, and I grew up in St. Louis at WashU with Dan Coyne, where anything that moved, we used to give IV iron to. So I'm very partial to IV iron. But there's a lot of people who grew up in different wells who keep giving oral iron till it's either very late or till you can demonstrate that by giving oral iron, you don't get your indices mitigated. However, I did present one slide where use of SGLT2 in the diabetic kidney actually improves the HIF-ESA nexus and actually improves endogenous ESA production and improves anemia levels. So I think there is a salutary response in that. I don't think it would change the way use of SGLT2 inhibitors will change the way the IL-6 hepcidin axis works, because that inflammation is pretty significant. We are running a trial, like I think I mentioned that during the talk, where we're using IL-6 blockers in healthy people at risk for cardiovascular disease to kind of see if that would decrease. So the inflammation is more than trivial in those cases, and the hepcidin levels are higher, and the block is significant. But your point is very well made.
Yeah, in my experience, I want to say our experience, my experience is diabetic or poorly controlled diabetic. They actually have more tendency to have iron deficiency anemia, and oral iron not helpful much, and they end up having periodically IV iron. At the same time, I thought that they are either were trying to make, or they are still trying to make some hepcidin receptor blocker, this kind of medication that probably will help on those patients in future.
Yeah, so I think if you really look at it, if you can actually block IL-6, you will actually decrease the release of hepcidin, right? So that's why the ferritin levels are so high in these patients, because that's the IL-6 on the liver, and that's where, so hepcidin and ferritin go hand in hand. So if you can use IL-6 in these patients, you can actually decrease the general inflammatory tone and maybe improve the efficiency of iron absorption. But that's probably what's going to come out from, and 3 or 4 companies are running these trials. There are different IL-6 blockers that are being used, and we'll just have to see what the profiles look like in a few years.
I think in future we should have one topic discussion on anemia in CKD, not on end-stage disease in CKD. It's a very important topic and sometimes very hard to manage it.
Sure.
So one last question by Dr. Afzal. He raised his hand.
Yeah, thank you. My question was written down in the chat box. It was the first question. And the question is this: let's suppose we have so many drugs that have long-term benefit and the short-term drop in GFR is expected. The classical teaching is that if there is a 30% increase in creatinine or the loss in GFR, you may consider decreasing the dose or holding it. Let's suppose we are using SGLT2 ARBs and some of the other drugs, and there is 20% expected rise with RAS inhibitors, but the rest of the contribution may be by the other drug. Would you add them serially in a patient who is more likely to have a decrease in GFR, or would you use a lower dose and institute a couple of those? How do you tailor that?
So I follow exactly how the trial did it. So I put, let's suppose I see somebody with diabetic kidney disease who comes in and they are nascent, they're on nothing, they're on metformin, right? And so what I do in these patients is I put them on an ACE inhibitor or an ARB, maximize the dose and wait 4 weeks and make sure that everything is stable there. Then I add the SGLT2 inhibitor, give them 4 to 8 weeks. So these things are like Omar said, it's not like an antibiotic that needs to be maximized the next day. These are things that you're introducing for the next 10 years, next 15 years. So you want to make certain that an initial rush towards maximizing everything doesn't land you in a spot where you have to pull everything back, because now they're an acute kidney injury and they've lost faith in these agents Because, you know, you and I can talk about hemodynamic change and no structural kidney disease till we are blue in the face. When you have somebody who has to go do repeated labs, or worse, have to go into the ER because their creatinine went up or the potassium went up, they would lose faith in you and the drug. They would say, Doc, you put me on something which landed me in the ER. I'm not going to come do this again. So you have to be very patient, very vigilant, careful. If you've got somebody on 2 or 3 diuretics and I'm starting them on an SGLT2 inhibitor, I may hold one diuretic or cut the doses in half so that I don't dry them out. So everything has to be done carefully and methodically. But if you pay just a little bit of attention, and you know, most of our nephrologists do that, we run into these issues when sometimes the primary care doctors try to do it and they kind of fall into a ditch and send the patient to us allergic to SGLT2 inhibitors because had acute kidney injury or something like that. Then it's twice as hard to get the patient back on the bandwagon. But no, sequence carefully, one by one. It may take you a year to get them on their definitive regimen. What's the rush? Get them on their definitive regimen in a year.
Thank you, everyone. I think we are at 301 now. So maybe I would present a motion to adjourn. So I'm sure the talk, but this will be available in it will show up in YouTube in near future. So thank you, everyone. Thank you for restarting, resuming, and showing up with good passion, rigor, and asking all these wonderful questions. And very grateful for outstanding speakers and panelists for a really interesting and involved discussion. So thank you. सबको पाकिस्तान में तो बहुत रात के मतलब अब तो काफी देर हो गई है, सब लोगों ने सोना है, तो
सबके 12 बज गए पाकिस्तान।
तो आप सोएं जाके, तो फिर इंशाल्लाह जो है ना अगले महीने फिर मुलाकात होगी। खुदा हाफिज।
Thank you very much. So nice.
Everybody in Pakistan.
Allah Hafiz. Thank you.